Hi, everyone. Just to check, can people hear me okay? Is there any issues? Just mention in the chat. Arif, if you could just put it on, you're still on presenter mode at the moment.
Okay, is that okay?
That's okay. Hi, everyone. Thank you for joining us today. My name is Bianca, and I'm one of the chairs at SUPTA. This week, we are going to be focusing on cardiothoracic surgery, and we're excited to have you all with us. Today, I'm joined by Arifa, who will guide you through the cardiothoracic surgery session. And Arifa is a third-year medical student from Buckingham. So to make this session as engaging as possible, Arifa will be asking you questions throughout. Just answer these questions in the chat using the chat function. And if you have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we will be releasing some poll questions as well for you to have a go at. We'll also share a feedback form at the end of the session, and if you complete this, you will receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and Pass the MRCS. This session will be recorded, and the recording and slides will be shared on our medal page a couple of hours after, so be sure to keep an eye out for that. We're also excited to share that we have an exclusive question bank and other resources that will soon be available on our learning portal, so be sure to check out our website to access them. And if you create a free membership account with us, you'll automatically receive a discount code for 10% of all the Geeky Medics anatomy flashcards, surgery flashcards, and knowledge bundle. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons, Geeky Medics, MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. Thank you so much, and I'll hand over to Arifa.
So hi everyone, my name is Arifa Qureshi. I'm a third-year medical student at the University of Buckingham, but currently I'm doing my placements at Buckinghamshire Healthcare Trust, which is in Aylesbury. So today I'm going to be talking about cardiothoracic surgery, but specifically valvular heart disease and coronary artery disease. I'll try to ask a couple of questions throughout the session just to see if you guys are able to recall what I've said, and you can put your answers in the chat, and the coordinator will look through them and then let me know what's said in the chat, as I can't see it. Okay, so let's get started. So the learning objectives for today are, I'm just going to be going over basic anatomy of the heart and its clinical significance, a little bit about the electrical conduction of the heart, and then specifically going into the most important valvular heart diseases that you need to know, and their coinciding murmurs, presentations and risk factors for coronary artery disease, and a little bit about the pathophysiology. And finally, talking about ACS, acute coronary syndrome, management, and a little bit about the surgical options that are available, including PCI and CABG. If you guys have any questions throughout, you can put them in the chat and I'll try to get to them. Okay, so anatomy of the heart. There are 4 chambers, as most of you already probably know. There's a right atrium, the right ventricle, the left atrium, and the left ventricle. And these 4 chambers are where the blood flows through. So there's a pathway of the blood that flows through the heart, which I've included over here. So again, the deoxygenated blood from the body comes through the IVC and the CVC, which is the inferior vena cava and superior vena cava. And then it goes through into the right atrium, and then through there, it goes through the tricuspid valve into the right ventricle, and then from the right ventricle, it goes through the pulmonic valve, through the pulmonary artery into the lungs, where it gets oxygenated, and then it comes back to the heart through the pulmonary veins. So there's the 4 different veins, and then it goes into the left atrium, and then through into the left ventricle through the mitral valve, and then out through the aortic valve into the aorta, and then to the rest of the body. So then the branches of the aorta then go to the head, the limbs, the upper limbs and the lower limbs and the rest of the body. So one thing that we need to start off when we're talking about anatomy is the layers of the heart. So I'm going to go from inside to outside. So the innermost layer is called the endocardium. So the endocardium is this portion right here. And the importance of it is that it helps in aiding with like the electrical activity, and it lines the heart and it regulates the contractions that are happening. And it's made up of loose connective tissue. Then after the endocardium, you have the myocardium. So the myocardium is basically the muscle layer of the heart, which helps in contraction of the heart. And it has your cardiac muscle type. And then after the myocardium, then you have the pericardium. So the pericardium has different layers. It has a visceral layer, a space in between, and then a parietal layer outside. The visceral layer, basically, it protects the heart muscle because it's right after the myocardium, and it creates the pericardial fluid, which is within the pericardial space. The pericardial fluid is really important for lubrication of the heart. And outside of the pericardial space, then you have the parietal pericardium. And then outside of the parietal pericardium, you have the fibrous pericardium, and that's the fibrous pericardium is important to protect the whole heart as a whole, and it prevents it from overfilling. So it prevents cardiac tamponade from happening, which is when you get a buildup of fluid outside of the heart, and that compresses the heart, and that can prevent blood flow from from going to the rest of the body. So now that I've talked a little bit about the layers of the heart, I want to go into specific detail about inflammation or infection that you can get of each of the layers of the heart. So again, we start from the inside. So endocardium. Inflammation would be infective endocarditis. And it's basically caused by various different bacteria like Staphylococcus aureus, Streptococcus viridans, Staphylococcus epidermis. So it depends on the patient demographic which organism is going to cause the endocarditis. There are like 3 cardinal signs that they love to ask in questions. I haven't really seen it in real life, but they are asked widely, is the splinter hemorrhages, the Osler's nodes, and the Janeway lesions. So splinter hemorrhages will be like these little lines that you see going through the nail, and then Osler's nodes and Janeway lesions will be found on like the palmar surface of your hand. And when you do like cardio examinations, you'll see people talking about whether they can see these signs or not. They're kind of like indicative of infective endocarditis. Other things that patients might present with are fever, chills, chest pain, muscle aches, just feeling unwell in general. And they may present with the aortic regurgitation murmur. I'm going to go in detail as to what that sounds like in the next couple of slides. The diagnosis for endocarditis is done using the modified Duke criteria. It's a very confusing criteria, but what I think you guys should know is that 1, you have to have done 3 blood cultures from different areas of the body, and they all have to be positive for a specific organism in order to say that the patient has infective endocarditis. And then they also are looking for like cardinal signs like the splinter hemorrhages, Janeway lesions, Osler's nodes, in order to say 100% whether they have infective endocarditis. Another test they like to use is an echocardiogram because they want to see if there's any basically lesions on the valves that are seen in echo, which are which arise during infective endocarditis. The treatment is, again, it just depends on the causative organism, but they will most likely just give you antibiotics which cover the specific organism that has caused the infection. Then we move on to myocarditis, so inflammation or infection of the myocardium, the main area where you're going to be having muscle contraction. There's a lot of different causes, but the main ones that they like to ask and that you should know are viral. So things like Coxsackie B virus, which is one that's asked quite a bit. HIV can cause it. Lyme disease as well, and protozoa. So there's like different protozoas that can cause it. One example is Chagas disease. There's various other ones. Myocarditis is slightly harder to diagnose because there aren't like cardinal signs that you're looking for. It's very like general symptoms, like they present with shortness of breath, chest pain. They may present with certain arrhythmias because of the heart is not able to contract properly because the muscle is inflamed. Diagnosis, again, they like to do things like inflammatory markers, and the troponin will probably be very high, very raised. BNP might be raised, and they may see arrhythmias, but it's mainly diagnosed by the patient's history. So like you want to see if they had a history of Lyme disease or some sort of protozoa infection or a viral infection, and is now manifesting as chest symptoms. And therefore, you would treat it based on the underlying cause that's causing it. And lastly, we're going to do pericarditis, so the outermost layer. And this is more common. They like to ask about pericarditis quite a bit. Causes, again, Coxsackie B and other. It also can cause pericarditis as well, viral. Bacterial cause for pericarditis, high yield TB. They always like to say TB. You can have post-MI pericarditis. So there's like different complications that you have post-MI. One of them being Dressler syndrome, which happens like 2 to 4 weeks after, and that's a type of fibrous pericarditis that happens. And also certain connective tissue disorders like lupus or rheumatoid arthritis, again, high risk. So if you see in a history, patient has RA or lupus and is presenting with some sort of chest pain, think pericarditis. Symptoms, these two are very, very important to know. Pleuritic chest pain, which is better on leaning forward, and a pericardial rub. So pleuritic chest pain, if you don't know, it's chest pain when you breathe in. So you get a sharp chest pain when you breathe in and out. Sorry, when you breathe in. And this normally relieves when you lean the patient forward. So if you ask the patient, oh, is there a specific position where the pain gets better or worse? And if they say, oh, it's better when leaning forward, start to think, okay, it might be pericarditis. Pericardial rub is this sound that you hear in the chest area. It's hard to describe, but you like can search it up and listen to it. But it's just this like rubbing, frictiony sound that you hear with your stethoscope on the chest. And then ECG changes, saddle ST changes, which means like there's basically elevation happening in most of the leads. You'll see ST elevation. You might confuse it with a STEMI. So then look at the history. It'll probably lean you towards one or the other. And PR depression. So your PR interval is normally depressed. So kind of like how in a STEMI you have ST depression. It's like that you would have PR depression. Diagnosis is raised inflammatory markers and troponin. So mainly pericarditis, they say that it's like a clinical diagnosis. So the cardinal signs of the chest pain that's better on leaning forward, and the pericardial rub and the ECG changes is what they would use. Treatment is NSAIDs, so any NSAIDs with colchicine. I know colchicine sounds weird. It's the drug that they use in acute gout, but it is, studies have shown that it works in the acute management of pericarditis, along with NSAIDs. So this is an example of a pericarditis ECG. So I know, like, you can see, I don't know if you can see my mouse, but you can see the ST elevation in lead 2, lead 1, lead V4, V6. So it does look very similar to a STEMI, but you should be checking the PR, and there will probably be like PR depression, and then also the history will lean you towards pericarditis as opposed to a STEMI or an ST elevation MI. Okay, so now we're going to go into the blood supply of the heart, which is quite important. So you have 4 very important arteries that you need to know. So you have your right coronary artery, your left anterior descending. So your right coronary is here, your left anterior descending, your left circumflex, and your posterior interventricular artery. So all of these have quite a bit of branches. So the right coronary artery has the acute marginal branch, the SA nodal branch, and the conus branch. So it basically supplies the right atrium, the SA, and the AV node, and kind of the right heart. The left anterior descending branches are the diagonal and the septal branches, and this supplies like the anterior part of the heart and the septum, or a little bit of the septum. And then the left circumflex has a branch called the marginal obtuse, and that one supplies the left atrium side of the heart. And then the posterior interventricular artery supplies the posterior septum. And this it kind of depends on the dominant circulation. So most people have their dominant circulation as a right coronary artery, so 80%, and the rest remaining 20% have it. The left side is their dominant circulation. So it just depends on what is your dominant circulation. Again, I've kind of already said this. So like the right coronary artery, where area it supplies is the SA and AV node, the right atrium, right ventricle. Left anterior descending is more of the anterior IV septum and the right ventricle, and a little bit of the left ventricle. The left circumflex does the left atrium and left ventricle. And then obviously the posterior interventricular supplies the posterior interventricular septum. Okay, so coronary angiograms. Coronary angiograms are basically ways for doctors to see how patent a coronary artery is. And it allows you to see whether you have any blockages in the arteries and whether that needs fixing. What they do is they basically send a dye, like a radio opaque dye, through either the radial or the femoral artery of the patient. And then this travels up through the arteries, through into the heart, into the coronary arteries, and then they start taking X-ray imaging of the heart to see where the dye is going through and whether or not there's any blockages. So these pictures that I've included are normal coronary arteries. So as you can see, there is like no blockage anywhere, and the dye is clearly going through the arteries. There will be some pictures in the next slide which show blockages. So here you can see, for example, on the left picture for the right coronary artery, there's a 99% critical stenosis, which basically means that there's 99% blockage in that artery and there's no blood flow going to that area. which means that patient is at high risk of having ischemia of the heart. And then when you see stenosis like this, the doctor or the cardiologist is probably going to be putting in a stent to open up the artery to allow for blood flow to improve. Or if it's very extensive, they may think about doing a CABG, which I will talk about towards the end, what a CABG is. Okay, so a little bit about cardiac veins. Cardiac veins are pretty simple. There's just the smaller ones, the middle ones, and the great cardiac veins. And they all drain into the coronary sinus, which opens up into the right atrium. So all of the deoxygenated blood from the heart is going into the right atrium and then going to be oxygenated again. Okay, so a little bit about the electrical conduction of the heart. So as you know, the electrical conduction, it goes through a pathway through the heart from one area to another and then goes throughout the heart to allow for the heart to contract. It begins at the SA node, which is like at the top of the right atrium, and then it sends its impulse to the AV node, and then it holds at the AV node, so that kind of correlates to like the PR interval where it holds at the AV node, and then it travels down through to the bundle of His, which is basically at the top part of the septum, and then it travels down the left bundle branch and the right bundle branch, and eventually goes into the Purkinje fibers, which are in the myocardium, and then it allows for the whole heart to contract and the ventricles to contract. So there's two types of cells in the heart. So this is a little bit going down to a cellular level, what is happening to allow for the heart to contract. You have your pacemaker cells, which have three phases, phase 4, phase 0, and phase 3. And then you have your cardiomyocytes, which have 5 phases, 0 to 4. So what happens in the SA node and AV node, which are the pacemaker cells, is that you have calcium channels opening. So your phase 0 is your calcium channels are opening and they're depolarizing the membrane. As you know, calcium is positive. So it's going to come in and it's going to depolarize the cell. Then you're gonna, as soon as the cell is depolarized, then the calcium channels are gonna immediately close and the potassium channels are gonna open and allow for potassium to go out to repolarize the cell. And then you have phase 4, which is kind of like a buffer phase to allow for another action potential to be to come again. And it just helps to maintain the resting membrane potential. The ventricular or the cardiomyocytes are slightly different compared to the pacemaker cells because they have 5 phases and they're mainly sodium, calcium, and potassium. So first step that's going to happen is you're going to have the sodium channels open and they're going to quickly depolarize the cell, and then which is phase 0, and then at phase 1 you're going to have the sodium channels close and the potassium channels open for a bit, and so you have a little bit of repolarization happening, like your initial repolarization it's called, and then right after that there's going to be calcium channels open. So as soon as the calcium channels open, you have a lot of positive ions coming inside, and therefore you're having a plateau. So like there's some leaving and there's some coming in, so you have a plateau stage, which is your phase 2. And then once the calcium has come in, then the calcium channels close, and then you have the potassium channels that are already open, and then you have the final repolarization happening, which is your phase 3, and then phase 4 again to allow for resting membrane potential to be reached, and then another action potential will then, and then the cycle will repeat itself. So now we're going to move on to valvular problems. There's a lot of information in the valvular problem slides. Don't get overwhelmed by the amount of information that's on there. I'll try to keep it as simple and easy to remember as possible. So first, before I start off by talking about any problems, I need to talk about what the valves are. So you have your semilunar valves, and then you have your atrioventricular valves. So your semilunar valves are the ones that are found between the ventricle and the blood vessel. So your aortic and your pulmonic valves. And the AV valves are the ones which are found between the atria and the ventricles. So your tricuspid and your mitral valve. And when you think about it, there's only two problems that can happen with each valve. Is either they can become stenosed, which means they become narrowed, or they can have regurgitation, which means there's retrograde blood flow through the valve. So instead of going one way, the blood is flowing back the other way, and therefore you're getting regurgitation of the valve. An easy way to remember it is it's a leaky valve. Before I start to tell you what the heart murmurs are for each specific valvular disease, I'm going to just explain what murmurs are. So murmurs are any added heart sounds that you may have. So as everyone knows, there's two heart sounds, S1 and S2. Murmurs are any additional or added heart sounds that you might hear either in between S1 and S2 or between S2 and S1. Systolic murmurs are something that you're going to be hearing between the first heart sound and the second heart sound. They can be different types. You might hear like a crescendo, decrescendo sound, or you might hear a like a pan systolic sound, which is just the same sound throughout. Or there may be, it gets louder and then softer again, which is crescendo, decrescendo. Diastolic is going to be between your second heart sound and the next first heart sound. So a way to kind of figure out if something is systolic or diastolic is while you're listening to the heart for a murmur and you hear something, also palpate the patient's pulse, radial pulse at the same time, because that helps you to figure out, okay, this beat S1 has just passed and I hear the sound after S1. So then I know that it's going to be systolic. Or the opposite, if it comes after S2, then you know that it's going to be diastolic. There's different ways of describing it, as I've said. So you have your timing. So either it can be early, mid, or late. They can either be crescendo, decrescendo, so becoming loud and soft. They can be ejection, so at the ejection. They can be rumbling. There's different ways of describing murmurs. It can radiate to different areas. So you may have it radiate up to your carotids. You may have it radiate to your axilla, the apex. You might have to get the patient to do certain maneuvers to make it sound louder and to hear it better. And I'll talk about what some of those maneuvers are when I talk about the specific valvular heart disease. Intensity-wise, there's a way of grading it. Grade 1 to grade 6. Grade 1 being it's very soft and like it's very hard to hear. And grade 6 means you can actually hear the murmur just from standing close to the patient. You don't even need like a stethoscope. That's how loud it is. So it's just kind of the intensity of how loud the murmur is and how easily you can hear it. Okay, so the heart valves. So where am I going to listen? How do I know where to listen? So there is different areas of auscultation, so auscultation points that you should know, and they all correspond to the different valves that you're listening to. So beginning, the aortic valve, start with the aortic valve. The aortic auscultation point is the second intercostal space, right sternal edge. So basically, you feel for the angle of Louis, which is in this picture, and then that's kind of where you can feel the second rib, and then you just go below that and find the intercostal space. And then just right to the sternum is where you will listen. Sorry, just right to the sternum. And then the pulmonic valve will be in the same plane. So it will be second intercostal space, but it will be on the left side of the sternum. The tricuspid area will be the fourth intercostal space, left sternal edge. So the rest will be all on the left side. And then the mitral or the apex will be on the fifth intercostal space, left mid-clavicular line. So find your clavicle and move down to where the fifth intercostal space is, and that's kind of where your apex is. So you can palpate for the apex beat over there as well. And you can listen to the mitral valve over there as well. And a way that I like to remember the order from right to left is like this little mnemonic called all patients take medications. So A for aortic, P for pulmonic, and then take tricuspid medications, mitral. It's just a way to remember the order of the auscultation points. Herb's point is something that they use for specific valvular diseases. It's not as important to know it, but you can know it. It's third intercostal space, left sternal edge. So kind of right between the pulmonic and tricuspid areas is where Herb's point is. Okay, so we're going to move on to the actual valvular heart disease. So one of the most common ones is aortic stenosis. Why? Because it's just very common in the elderly population, because literally the most common cause is calcification or wear and tear. Mainly happens in the older population. It may be because someone had a bicuspid aortic valve, because normally it is tricusp, so 3 cusps. But if someone has 2 cusps, it may prevent it from opening entirely. Also, rheumatic heart disease sometimes, and hypertrophic obstructive cardiomyopathy. But I think the main ones to know is it's calcification or bicuspid aortic valve. The way to remember the symptoms is remember SAD. So aortic stenosis makes you sad. Syncope for us, angina as in chest pain, and dyspnea as in shortness of breath. So mainly they will present with those 3 symptoms. And then you would think, okay, let me listen to their heart. And then you would probably hear an aortic stenosis murmur. And this aortic stenosis murmur will be an ejection systolic murmur, which radiates to the carotids. It's very like loud. So right after the first heart sound, as soon as the first heart sound happens, you hear like this loud murmur that's happening, and it's very loud, and then it dies down a bit. So that's kind of a way to listen to it and like remember that this is aortic stenosis. And it radiates to the carotid. So always listen to your carotids when you're doing a chest examination, just to see if there you can hear any murmur there. Management wise, on the intensity of the murmur, the intensity of the stenosis, and symptoms. So if they're symptomatic, or their valvular gradient is greater than 40, then you want to do an aortic valve replacement. You don't really need to know about the valvular gradient a lot. Just know that if it's very symptomatic or it's very stenosed, then that means you want to do an aortic valve replacement. There's 2 different types. You can either have a metal valve or a prosthetic valve. The metal valve it lasts longer, but it requires you to be on a medication for your whole life. And then the prosthetic valve doesn't last as you don't have to be on a certain. So they kind of weigh up the options when they decide which one to do for a specific patient. If they're symptomatic but not fit for surgery, so someone who has like lung conditions, like very severe lung conditions, or they're just won't be able to manage anesthesia in surgery, then you would do a TAVI, which is called a transcatheter aortic valve implant, I think. So they basically kind of put a catheter in between the stenosed valve to allow for the blood flow to continue through. If there's severe aortic stenosis, they can do a balloon valvuloplasty, but it's not very commonly done. They normally stick with either valve replacement or TAVI. Aortic regurgitation. Again, as I said, regurgitation means that there's a retrograde blood flow. So basically, there's blood flowing from the aorta back into the left ventricle. So basically, not enough blood is being transferred to the rest of the body because it's coming back into the left ventricle when it's contracting. Causes are, again, connective tissue disorders. So things like Ehlers-Danlos syndrome or Marfan syndrome, because they cause loss of elastin. So you have lots of, you get like regurgitation of the valves with those diseases. Rheumatic heart disease, again, can cause aortic regurgitation, infective endocarditis, aortic root dilation, and again, bicuspid aortic valve can also lead to regurgitation, not only stenosis. I think the main ones you guys should know from this is connective tissue disorders and rheumatic heart disease. In terms of symptoms, they'll present with, again, similar symptoms. So you have shortness of breath. You probably wouldn't have chest pain as much. You have something called a collapsing pulse. It's basically when you're checking the radial pulse and then you swiftly lift their arm up above their head, and then the pulse becomes very like throbbing and thready kind of thing. You might have a wide pulse pressure, which basically means the systolic to diastolic pressure, there's a very big gap in between it. And then there's these two other signs, don't really worry about them at this point. It's like one of them is pulsating of the nail bed, and yeah. So for the murmur, though, it's an early diastolic murmur, which is increased with hand grip and expiration. So what you want to do is you want to get the patient to breathe out while you're listening to the murmur, so it will accentuate the murmur. And this is, again, early diastolic. So as soon as you hear like your S2 sound, you start hearing the aortic regurgitation murmur, and it will kind of last your whole time till your till your S1 again, so the next heart sound. Management-wise, it depends. Again, if you're symptomatic, they always want to do an aortic valve replacement. And also, if it's asymptomatic, but they're having like left ventricular dysfunction symptoms or signs, then you also want to do an aortic valve replacement. Mitral stenosis. So mitral stenosis, main cause, you have to know rheumatic heart disease. It's literally one of the only causes which causes mitral stenosis. And then there's some rare things like carcinoid and things, but mainly you want to know rheumatic heart disease. Very vague symptoms. You have shortness of breath. You might have coughing up blood, hemoptysis. You might have chest pain, but very vague symptoms. So again, they listen to the heart and they might hear the murmur that's bringing them more towards a valvular heart problem. This presents with a mid-diastolic murmur with an opening snap, which is better heard on the left lateral decubitus position on expiration with bell. That's a lot. Basically, what it means is that the murmur you'll hear kind of a little bit after you hear the heart sound, and it's heard best when the patient is on their left side. So you'll ask them to, while you're listening, just kind of roll themselves onto their left side and ask them to breathe out. And that's when you you'll hear the murmur the loudest. And you're going to be listening on the mitral area, which is closer to the fifth. So it's on the fifth intercostal space midclavicular line. For management-wise, if you have atrial fibrillation along with, then you think putting them on some sort of anticoagulation, so warfarin. If they're asymptomatic, then you just want to monitor them, make sure that their heart is, the blood flow is still going through regularly, and you want to do echocardiograms just to make sure they're okay. If they're symptomatic, then again, you either do a mitral valve surgery, so either you replace the valve or you can put in a balloon to open up the valve. And then you have mitral regurgitation last, which again, it's caused by ischemic heart disease or post-MI. That's a really important thing, is post-MI, someone might get like acute mitral regurgitation. It's one of the very common complications that happens after a heart attack. Mitral valve prolapse might cause it, and mitral valve prolapse is associated with a lot of different diseases like polycystic kidney disease, other connective tissues like Marfan syndrome. Again, rheumatic heart disease again can cause mitral regurgitation as well, but not as common. It's normally asymptomatic. You might have some arrhythmias, and you might have pulmonary hypertension because of the backflow of blood, and pulmonary edema in the lungs, again, because the blood flow is backing up. The murmur you hear will be a pansystolic murmur. Pansystolic means throughout the whole time between the S1 and S2. And again, it's best heard on the left side, but instead of using, sorry, I didn't mention, but in the mitral stenosis, you use the bell of the stethoscope, and for mitral regurgitation, you use a diaphragm, which is a bigger side, to listen. If it's acute mitral regurgitation, so again, like post-MI, then you want to give them things like nitrates or diuretics or inotropes, so like to increase blood pressure and heart contraction, or a intra-aortic balloon pump. If you're seeing any signs of heart failure because of the mitral regurgitation, then you want to give the drugs that you give for heart failure, which are ACE inhibitors, beta blockers, and spironolactone. And then again, if it's very severe, then you want to take them for surgery. Tricuspid regurgitation is basically the same as mitral regurgitation. I just made another slide about it, because the causes are due to right ventricular problems like right ventricular infarction or pulmonary hypertension. You may hear like a parasternal heave, which is basically when you put your hand on the chest, you feel a heave right in the middle. And the murmur is the same as a mitral regurgitation murmur, so it's just pansystolic murmur. And again, if it's symptomatic, do a valve replacement. Pulmonary stenosis is another very common one. And the causes are congenital heart diseases. I don't know if you guys have heard of Noonan syndrome or tetralogy of Fallot, but it mainly presents with something congenital in children. You might have a raised JVP with giant A waves. You may have some peripheral edema or feel thrills on the pulmonary area. It will be an ejection systolic murmur, loudest in the pulmonary area with taking a deep breath in. It becomes louder. So ejection systolic is the same as aortic stenosis. So the actual murmur won't sound different. It will just be loudest in a different area. So it will be louder in the pulmonary area rather than the aortic area. and then you treat the congenital heart defects with surgery, and that will reverse the pulmonary stenosis. Okay, so that's all about valvular heart disease. It's quite a bit to get your head around, but I think the more you go through it, the easier it gets to remember the murmurs and things. One really useful tip that I learned from someone was, if you want to remember which one is systolic and which one is diastolic, then remember Mr. Pass and Mrs. Ards. So Mr. Pass is mitral regurgitation, and aortic stenosis is systolic murmurs. And then Miss Ards is mitral stenosis and aortic regurgitation are diastolic murmurs. If you can't remember anything, I just remember that, and it tells me whether one is systolic or diastolic. Okay, now moving on to coronary artery disease. There's a lot of steps of pathophysiology. I'm just going to try to put all of these steps into like 1 or 2 sentences. What happens is you get endothelial damage. So as you know, that the arteries are lined with endothelium, which is the innermost layer of the artery, and this gets damaged due to a lot of different causes. Like it might be due to hyperglycemia, so type 2 diabetes. It might be due to hypertension because there's high pressures of blood going through the arteries. Smoking, because of certain chemicals that come from smoking that may damage it. Basically, these damages cause you to get buildup of plaques within the artery, because your body is, the changes to the endothelium is allowing for a lot of inflammation to happen in that area, and then you're also getting the movement of the lipoprotein particles coming into the lumen, and again, there's macrophages that come and then they oxidize, they kind of eat these LDL cells and then create foam cells. And the foam cells basically go inside the tunica media and line up in there. And then they create this like big plaque, which occludes some of the lumen. And then once that plaque ruptures, then you get things like thrombus forming, and then you have ACS, which is acute coronary syndrome. So that's how heart attacks and unstable angina happens. So this is like a picture of what's happening. So you have your LDL, which is being phagocytosed by the macrophage, and then it's creating the foam cells and then going into the smooth muscle in the tunica media and then creating this plaque that's occluding. And then first it starts off with like a fatty streak, a very small plaque, and then continues to grow and grow and grow. And then once it gets ruptured, then you get thrombus formation, and that completely occludes the artery, and then that's when you get your ischemia to your heart muscle. Before I move on, I mean, the next slide is on risk factors. I want to see if anyone actually knows any risk factors for coronary artery disease, modifiable or non-modifiable. Oh, I can't see the chat. If someone can read if there's anything there.
Not as of yet. Oh, yep, we've got some. Smoking, alcohol, diet as modifiable factors.
Yep, so smoking, alcohol is correct. Diet, for sure.
Diabetes.
Yeah, diabetes is one. Okay. Well, thank you for putting your answers in the chat. I'll move on. So again, as people said, modifiable, you have your smoking, you have your alcohol, you have certain comorbidities, like as people said, diabetes, you have AF, hypertension, obesity is another one that's modifiable, high cholesterol, and sedentary lifestyle. And then you have your non-modifiable ones, which are like age, gender, as is more common in males, family history, like positive family history of maybe cholesterol problems, and your ethnicity. Okay, so now I'm gonna go on to explaining ECGs a little bit, and which leads you're looking for which areas of the heart. So for inferior leads, you're gonna be at your leads 2, leads 3, and leads AVF. So that is what the inferior part of the heart is supplied by the RCA, so the right coronary artery, and or the left circumflex. So whenever you see any changes in 2, 3, and AVF, you're thinking, okay, right coronary artery and inferior. For lateral leads, you're looking at your leads 1, leads AVL, V5, and V6. And that is commonly supplied by your left circumflex. And your anterior septal, so your V1 to your V4, you're going to be looking at for your left anterior descending. So if you see any changes in that, then you're thinking, okay, the left anterior descending is probably damaged or occluded. So it's really good to look at pictures like this to remind yourself which areas correspond with which things, because a lot of questions are asked about there are certain changes in this ECG, which area of the heart is being impacted, which artery is occluded. So try to learn it. This is just another picture that I found looked really nice. It gives a little bit more detail in anteroseptal versus anteroapical versus anterolateral. But again, it's still kind of the same anteroseptal area as V1 to V4. And then you have your inferior 2, 3 AVF, and your lateral is going to be 1 AVL, and then V5 and V6. Okay, so now I'm going to move on to the different manifestations of coronary artery disease. So you have stable angina. So stable angina is basically when you have chest pain on exertion. So why are you having chest pain on exertion? It's because when you're exerting yourself, you have a faster heart rate. And when your heart rate is faster, your diastole shortens. So your systole actually stays the same, but your diastole is the one that shortens. And diastole, as everyone knows, it's the stage at which the heart is getting blood. So the coronary blood flow is high in diastole. But if you shorten the diastole, that means that you're shortening the amount of time that blood is actually getting to the heart muscle, and therefore you're causing ischemia to the heart, but only during exertion. So patients like this who present, they have chest pain only when they're like walking or when they're running, but then there's no chest pain at rest. And in the picture, you can kind of see the stable angina is like there's just plaques growing, but there's still blood flow going through. There's no thrombus, no blood clot formation in it. Therefore, at rest, they're okay. One thing to know is that you won't see any ECG changes or any raised troponin. So that's something we do every time someone comes with chest pain. You want to do an ECG on them and you want to do a troponin on them just to make sure. And since there's no ECG changes or any raised troponin, then you know that it's not acute coronary syndrome and that they can be managed outpatient. It's relieved with nitrates. So nitrates is like a vasodilator. So they give it to them and that dilates their vessels, and then they don't feel the chest pain anymore because their vessels are dilated enough to allow adequate blood flow to go through to the heart. Treatment-wise, you have things like GTN spray, which is a nitrate spray that you can give acutely if they have chronic stable angina. So they're presenting many different times with increasing chest pain. Then you can try giving them beta blockers, or you can try long-acting nitrates, which are given like once or twice a day, and they last the whole day. Okay, then unstable angina. So unstable angina is when the plaque has ruptured. So you have a thrombus forming, but it's not completely blocked. Hasn't completely blocked the artery, and therefore you'll have chest pain. But in this case, you will have chest pain at rest, so it won't only be on exertion. But you won't see any ECG changes because there's no like active ischemia happening. And then you will have a raised troponin. So as I said, when someone comes with chest pain, we do an ECG and we send a troponin right away. And so we kind of, since there's no ECG changes, we're thinking, okay, it's not an acute MI. And then the raised troponin comes back, so we know, okay, this is like the step before an MI. So they treat it as an NSTEMI. While waiting for the troponin to come back. And then once it comes back, they kind of treat it as an MI by giving them morphine, oxygen, nitrates in the acute setting, and then aspirin. And then they may go for a angiogram just to check where the blockages are and whether they will require a stent or not, but not acutely. They would go more like as an outpatient. Then we have NSTEMI. So non-ST elevation, myocardial infarction. Again, it's caused by ruptured plaque, and then you have your thrombus forming, where you're having a completely blocked artery. The reason why it's called non-ST elevation is because it's subendocardial ischemia, which basically means it's only the endocardium, which is being infarcted, so it has ischemia, but it doesn't go through the whole thickness of the heart, and therefore it's not going to cause ST elevation to happen. It's going to cause ST depression to happen. Again, you will have chest pain at rest. You would have ST depression, as I said, and you may see T wave inversion. And then you will have a raised troponin. The treatment for NSTEMI is acute MI. Everyone they treat with MONA, so morphine, oxygen, nitrates, and aspirin. Nitrates is when the patient has hypotension because it just makes it worse. You can give fondaparinux, which is basically an anticoagulation medication. If you're not going to be doing PCI, and you're going to calculate something which is called a GRACE score, and if you score more than 3%, then you're going to want to do a PCI within 72 hours. I'm not going to go into what the GRACE score is because it's going to take a while, but it's basically just a scoring system that they use to see whether an NSTEMI would require a PCI or not. So basically the intensity of it and whether it needs stenting immediately or can wait till later. This is how an NSTEMI ECG would look. And then, as I said, you'd see things like ST depression in the leads. So can anyone tell me which artery is being occluded in this? Or which area of the heart? I will accept anything.
We've got people saying anterior.
Anterior? Okay. I see what you guys mean, because it could be a bit, there's a little bit of depression in V2 and V3, and V4 prominently, I see.
Another answer is global.
It could be global. I was thinking more that it was lateral, so like left circumflex, because I see most in one V5 and V6, and then V4 a little bit. It could be global as well. So you're not wrong. This one is kind of tricky. The other ones will be a lot more obvious as to which area is being impacted. Okay, so STEMI, which is the last one, is an ST elevation myocardial infarction. It is the most extreme one, most extreme type of ACS, because you're having transmural ischemia. So the entire thickness of the heart is being damaged and therefore causing the ST elevation to happen. So again, chest pain at rest, ACS. ECG changes, you will see ST elevation, or you might see a new left bundle branch block. This is a new thing that's coming into practice, that if you are seeing any left bundle branch block, which wasn't there before and it's recently arisen, it's kind of indicative of a STEMI. So people say to look out for that, even though there might not be ST elevation, prominent ST elevation. Left bundle branch block is also a sign, so you should flag that up. Another thing to look for is reciprocal changes in opposite leads. I'll show you in the ECG on the next slide what I mean by reciprocal changes. And then you'll have a raised troponin as always. MONA, again, treatment, same. Morphine, oxygen, nitrates. But for STEMI, you want to take them for a PCI within 120 minutes. That is the definitive management for this. If you can't get to a place where they're doing PCI, so PCI, let me say, is percutaneous coronary intervention. They put stents into the area which is fully blocked to prevent further ischemia from happening. If you can do it within 120 minutes, that's a gold standard. If you can't get to a hospital or a place which has PCI within 120 minutes, then that means it won't work after 120 minutes. So you need to think of thrombolysis, any way of breaking the clot rather than sending for PCI. So again, if no PCI, then you're going to give ticagrelor. Again, it's an anticoagulation medication, and you're going to thrombolize them. So the way you'll thrombolize them is with using TPA, which is tissue plasminogen activator. It basically will help to break the thrombus that has formed around the plaque. Okay, so this is STEMI. Can you guys tell me which artery is blocked in this? This one is much easier than the last one. Okay, that's fine if no one has answered. It's the left anterior descending artery. So you have prominent ST elevation from V1 to V4. And you can see how elevated the ST segment is in V2, V3, and V4. It's very easily prominent. And when I was saying about reciprocal changes, it means that you may see ST depression in the opposite leads. So things like you might see a little bit of depression in lead 3 and then lead AVF as well. It's not as clear, but you might see SC depression in the opposite leads. So you kind of look for that. Okay, so PCI, as I was saying, percutaneous coronary intervention, is basically when you send them for a coronary angiogram, and then it reveals the areas where you have blockages, and then these are opened with drug-eluting stents. Drug-eluting means that they have they're lined with medication that prevent rejection, so anti-rejection medications, so that the body doesn't fight the stent as a foreign body. So as you can see, like in the pre-PCI, there's quite a bit of extreme stenosis happening. And then once they put in the stents, you can see how patent they are now. And the dye is flowing through, which means that they were successful in putting the stent in. Okay, and then lastly, I'm just going to be quickly talking about CABG, or coronary artery bypass graft. This is basically a surgery that's done where they take a blood vessel from another part of the body and attach it to the coronary artery above and below the narrowed area. I have some pictures on the next slide. Basically, it allows for a bypass of a blood flow if the area of the blockage is too severe and they can't put a stent in to fix it, or there's many different arteries that have blockages in them. They will put in, attach an external blood vessel to allow for the blood flow to get to the heart. The vessels they mainly use would be the great saphenous vein, which is the large vein in your leg, because it's really big and it's easy to harvest. They might use the left internal mammary artery or the radial artery. Radial artery isn't commonly used anymore. It used to be used, but now mainly they use the saphenous vein and the left internal mammary artery. The reasons why someone might think of doing a CABG rather than a PCI or stenting is if they have triple vessel disease. That means that the three of their major vessels in their heart are blocked. So your right coronary, your left anterior descending, and your left circumflex all have atherosclerosis in them. Or if they have the left main vessel, so the left coronary artery has more than 50% stenosis, because the left coronary artery supplies significant part of the heart through the left circumflex and left anterior descending. If there's significant disease or there's quite a bit of symptoms despite maximal medical therapy, so they've tried everything and there's still significant atherosclerosis and they're high risk, then they would think about doing a CABG rather than medical management. A couple of pictures that I thought were really useful to show you what they would do. So you can have either single, double, triple, or quadruple CABG. So it just depends on how many of the vessels are actually blocked or completely blocked and require a alternate blood flow. So basically, they're attaching it from the heart, the vessel from the heart to the aorta to allow for the blood flow to go in. And then lastly, I'm just going to talk about CABG complications. These are just like very common things that arise post-CABG. So you want to make sure that you're monitoring a patient after their surgery. They may have atrial fibrillation, which is an arrhythmia. They may have had some bleeding that happened, or increased bleeding that happened during or after the surgery, which needs to be dealt with. They may get an infection where they had incision, so like where they were harvesting the nerve, or harvesting the vein or vessel. They may have thrombus formation, which can manifest as either stroke, either a heart attack, or PE. PE is pulmonary embolism. And then acute renal failure. Again, I put a picture of all the complications that can happen. They're not all that common. The ones that I've listed are the most common ones, but you can go through that if you want and find out a little bit more about complications that may arise. Thing to remember is postoperative medications. So after someone has had a CABG, you want to put them on a dual antiplatelet therapy. And that includes aspirin and a P2Y12 inhibitor, which an example is clopidogrel. So you want to put them on antiplatelet therapy. I'm not sure the length that they put them on for, but that's something that you want to consider after someone has had a CABG. And thank you so much. That completes my whistle talk tour on valvular heart disease and ischemic heart disease. These are the partners, and these are my references. And thank you so much. If you guys have any questions, then put them in the chat. I think I'll be able to read them now. And then
thank you so much. Oh, sorry, go on.
I was just going to say they're going to post some questions that I've created into the poll, so you guys can answer those as well.
So yeah, I'm just adding the poll questions and see them. They are in chat. We'll give you a couple of minutes just to answer the poll questions before I take you through a little bit of a run through the learning portal, and then I'll close the session. Thank you so much to Arifa for putting together this talk, the tutorial, and all of the content. Okay, so in the meantime, whilst you guys are having a look at the poll questions, I am just showing you guys. So you should be able to see here, this is the learning portal. So as you go onto the SUPTA website, if you click on learning portal, you should be able to create an account, access to all of our resources on here. So if you click on learning portal, as you can see here, these are what I'm doing. So if we go on today's session, coronary artery and valvular disease. So the video recording will also be displayed on here, so you're able to see it again if you missed it. It will also be on the medal, but this can be used in the future, for example, say if you want to use it back for revision again. And we've also got all the info in the session as well, and the main things you guys need to know for exams. And questions to test your knowledge as well. All of the topic series. For preoperative care, for example, we have the video, we have information, and we have some questions. Any additional resources will be displayed. Perfect. So if anyone wants to ask for any other questions, please put them in the chat before I just kind of give a closing statement. Perfect. Well, thank you so much, Arifa, for this amazing presentation. The feedback form has also been put in the chat. Please don't forget to fill it out so you can get your certificates and the discount codes for Teach Me Surgery and pass the MRCS. Also complete the Google form, which is in the chat message that I put in place just before the feed, so you can get a chance to win free access to the Geeky Medic surgical flashcards. And our next session will cover lung cancer, part of the cardiothoracic surgery series, and that is. And we'd love to join you again. Please follow us on our social media platforms, and we'll also be posting some short single best answer questions that Arifa has made for additional practice, so keep an eye out for those. We hope you found today's session engaging and valuable, and thank you once again for joining us, and we look forward to seeing you at our next session. Hi, sorry guys, unique code has just been put on the chat, 15694. Thank you so much, everyone, for attending.